Okay, I think it is 2 o'clock. So I think we can get started, and hopefully the people who are wanting to be with us will come on shortly.
I really like Jim's dynamics. He's got himself set up with Shekinah glory there all around what he's saying. So we'll all tune in just with absolute, utter amazement about his words. Thank you, Jim.
Yeah, I'm not sure exactly why that is. I've got Lake Winnipesaukee behind me and a bright light above me, and somehow it creates this aura. Yeah.
And I was going to say your halo is shining unusually bright.
Yeah, right.
We'll give you full credit, Jim.
Leverage it, Jim. Leverage it.
Yeah, right.
All right, great. All right. Well, now you've met both Dan and Jim, but let me give you just a brief introduction. And first of all, welcome to all of you who are just coming now. As I've said, as we got started earlier, we are really appreciative that you're here on a beautiful July Sunday afternoon. If you have friends or other people who are interested in this, we will be recording it so that we can share it on our website, but it's always better in person. So, or as close to in person as we can be here. So quick introductions. And this is really fun for me because both Dan and Jim are longtime friends. And also longtime supporters of the BPRG. So I feel so honored and excited that both of you are here. So Dan and I were together in medical school, which means a long time ago. And he is the co-founder and the chief medical officer of Enthea. He's been a senior physician executive with 30 years of experience in direct patient care as a psychiatrist, healthcare administration leadership, managed behavioral healthcare management, and healthcare consulting. He has worked in high-level positions with the Beacon Health Strategies, Tufts Health Plan, Evolent Health. Is that the right way you say it? Or Evolent?
Evolent, yeah.
Evolent Thanks Health and Fallon Healthcare, amongst many other organizations. And Jim is a local, meaning Boston-based healthcare attorney who has been advising Enthea. So in his work, he advises healthcare payers and providers, trade association and service providers on business matters, legislative and regulatory issues, and governance and personnel matters. He's also a national speaker and author of the ACA, Medicare and Medicaid policy, and Social Security. For more than 10 years, he was the CEO of the Tufts Health Plan. He also chairs the Rules and Bylaws Committee of the DNC and volunteers as legal counsel for the Mass Democratic Party and has co-chaired the Mass Hospital Association's work group on access to behavioral health care. So we are very lucky to have both of you. I also want to make mention of the fact that Sherry Race, who you know here as our magician making all of this happen, is actually the interim CEO of Enthea. And we will be learning more about Enthea within the context of an innovative system being proposed to be used to ensure clients with these medicines. So with that, I'll pass the baton to you. Thank you.
Great, thanks, Anne. Maybe I'll just quickly give a quick preview of what we're going to try and do here. And as you know, we're going to talk about the issue of health insurance and how these future treatments get paid for. Jim and I are going to sort of co-present. I'm going to do the dry stuff, and Jim is going to offer the color commentary as we go along in a spontaneous and unrehearsed performance here. We made, because slides, people sometimes want slides. So we have exactly 2 slides. Maybe we can show them now. The more important, neither of them are terribly important, but would be the second one. And its intent is just, since you've heard sort of who we are, the second slide, if Sherry, if you have it, simply gives you all a rough idea of where we're going to try and go in the next hour. And if you don't have it, that's fine too.
I thought you were sharing it. I will pull it up in a second.
in the meantime, while Sherry's doing that, again, and thanks to you and to Sherry for letting Jim and I join you. And it's nice to see some faces familiar, some faces new, and it was a delight to be in the early breakout rooms and meet some new people as well. Sherry, don't worry about it. We can just go extempore. We good?
Go ahead. Yep.
Okay. Jim, you're good?
I'm ready to go.
Okay.
And I
So-
do have it for you now if you want.
All right, 30 seconds, not more.
There you go.
So that's roughly where we're headed. I'll give you a moment to see that, give you some idea of what we're going to try and talk about. Our other intention here is to leave as much time as possible for questions and discussion, because Jim and I both feel that that's really where things get more interesting. And while we're going to focus on the issue of health insurance and health insurance coverage for psychedelic assisted therapies, I think the title of this, we said something about the role of the larger healthcare system in psychedelic medicine. Not going to speak to that explicitly, but Jim and I both have a fair amount of experience in healthcare generally, so we're going to be quite open to questions. Good. So, in prior presentations, generally in this BPRG, you've heard a lot about research and other kinds of developments that have been laying the groundwork for the entry of psychedelic medicine into, the US healthcare system. You get regular updates from Rick as to what's happening at MAPS. And what hasn't been discussed much here has been, how will this get paid for? So full disclosure, I think what we're going to talk about is probably going to be quite a bit less exciting than some of the presentations you've had here, but I think no less necessary, because research is key, FDA approval is key, training of competent therapists is key, but getting this paid for is obviously equally important. So that's going to be our focus. So I wanted to set the stage very quickly. What's a world without health insurance? And that was true. You have to go back about 70 years now in this country. Health insurance, gets mixed reviews, right? And it managed care, which has taken over the insurance world, gets a lot of bad raps, and some of it is well deserved. On the other hand, a world without health insurance means that therapies really are a private transaction between a provider and a client, and they have to agree on the treatment and they have to agree on the cost. And the obvious problem is that most of us cannot afford the expense of healthcare services when we need them on our own.
So I'll just jump in with a little bit about my take on it, which is that health insurance can be, and in some cases is, an expansion of access to all kinds of healthcare, and in this case, to psychedelic assisted healthcare. Until we are at a point where everything that anybody needs is provided without any concern about payment. And I will posit, contrary to sort of general belief, there is nowhere in the world that is true. Until we are at that point, health insurance can be something that increases access to all kinds of healthcare, and to some extent, Obamacare and traditional Medicaid and Medicare serve that purpose most obviously, but also employer-provided health insurance, and we'll come back to that a bit.
Yeah. Well said, Jim, because it's not just about payment, but also about building the networks of a great variety of healthcare providers and services that an individual might not otherwise be at all aware of. So what is health insurance? You could come at it from any number of angles. In one sense, simply it's financial support from some third party to help pay for healthcare. Most commonly it's an employer or an insurance company working on behalf of an employer. And second most commonly, it's the state or federal government through, as Jim just named, the Medicare and Medicaid programs.
But,
From another
but
go ahead, Jim.
Obamacare brings individuals into that as well, who can pay directly through a state exchange.
Right, right. From another vantage point, it's a contract between a payer and a patient. And so it's an obligation from the insurer to pay for care. Sometimes there are, co-insurance or co-payments involved, but to pay for care, assuming that it is appropriate and indicated, and provided that both the healthcare providers and the patients adhere to certain expectations, and we can talk a little bit more about that if there's interest. But probably most importantly, the payer has some basic expectations of providers, and namely, none of this will surprise you, that the care is appropriate and it's indicated for the treatment of a health condition. And that's the role of medical policy, which is something I'm involved in at Anthea, to assess, is this treatment appropriate for this condition? And the second fundamental expectation, appropriateness, the second one is that the provider is properly trained, that they're competent to give the care that they are offering. And we can say a lot more about that. Another way you could think about it, and I mention this for a reason that I'll explain, is health insurance is, at the end of the day, a shared resource. It's a kind of community pool in which people contribute money in return for getting coverage for care when they need it. But as a community resource, which we don't tend to think of it that way often, it's a shared resource, it's a limited resource, and there isn't any individual entitlement, I'm going to do this and therefore you need to pay for it. There are some rules to the game. Another important piece that health insurance brings to the table and into the world that didn't exist previously is that it establishes pre-agreed upon prices for things. So imagine a world without health insurance. You go to a practitioner and you might have to, the way you do buying a car or getting a tradesman or any number of things, to have to negotiate the price. And imagine if you had to negotiate the price of all of the healthcare services, the cost of your medications. So an often under-recognized aspect of the health insurance world is all of that has been done ahead of time.
There actually, a little, a decade or so ago, was a lot of literature about how patients should take the responsibility to negotiate the price themselves. Nobody ever paid any attention to that.
Yeah. All right, so that's sort of just a very quick overview of ways to think about health insurance. And then we wanted to get to sort of what does this mean to providers, particularly providers of psychedelic assisted therapy, who treat patients, clients that can't afford to pay on their own. From the provider's point of view, it likely means joining some network of providers, of fellow providers, who agree upon receiving payment directly from a third party, from an insurer, rather than billing the patient directly. So what does joining a network mean? Break that out a little bit. And this will follow on sort of what I was talking about previously. It means that the payer, in order to feel comfortable that the service they are paying for is being offered by somebody who's properly trained, there's this process called credentialing, in which the provider submits some basic information about their licensing, about their training. But again, it's all to serve the payers need to be sure that the provider is competent and appropriate. There's a stage of contracting in which a provider then has to come to some agreement with the payer about the rates they will be paid, about the procedure codes, and now we're getting to sort of inside baseball. And again, many of you are providers, and some of you, this is all old news. I apologize for that. But procedure codes are sort of the language with which a healthcare provider tells a payer, this is what I did for this patient. And it in turn allows proper payment for what they do. So contracting involves agreeing to the fees you're going to get paid, the codes, the sort of language with which you're going to communicate what you've done. It also talks about the timeliness of payments, and also some basic expectations from the payer about quality standards and quality oversight.
So let me jump in
Good.
again for a second to say that I think for people who are in the field but haven't gotten immersed yet in getting paid for services, there can be an assumption that everybody with a proper license will receive payment from third-party payers. And that it just doesn't work that way. Insurers, as Stan has pointed out, want to have some process of their own to determine whether a provider is properly qualified and has remained qualified and has not had reasons to be disqualified. And sometimes providers do that on their own. Sometimes they'll do that through some sort of joint mechanism with other providers, but it is not automatic. And indeed, even as those of you who practice in the more traditional medical world know, there can be a fair amount of controversy about how efficiently and fairly this so-called credentialing works. And part of what we'll be talking about in a few minutes is how this gets adapted to a new therapy, like psychedelic assisted therapy, so that it works fairly and efficiently, both from the provider's point of view and from the point of view of the patient seeking care, so that the provider they want to use is available to them. The same thing is actually true with regard to coverage of medications by health insurance. I've heard it said in this community that, well, when the FDA approves a medicine, then insurers or then Medicare or then Medicaid has to pay for it. Not true. It has to be examined and approved by the relevant committee within the various insurers, whether they're private or governmental. Those committees are called P&T committees. Remind me, Dan, that's
Pharmacy and therapeutics.
Pharmacy and therapeutics. There we go. I could come up with the therapeutics. I was forgetting the pharmacy. P&T committees. And again, that is sometimes done by specific providers on their own. It's certainly done by Medicare on their own, but it's sometimes done by a coalition of providers. And so having a provider who is a payer who is more informed and more open to expanding both coverage of drugs and credentialing of physicians is of value.
Yeah, very, very important point that Jim is making. FDA approval is not the guarantee that it's then paid for. A recent example of that, which some of you may remember from the news, is there was an FDA approval, somewhat controversial approval of a drug for Alzheimer's, I believe it was. And in the end of the day, a number of major payers decided we are not going to cover that. It's fully FDA approved because they just weren't convinced that it actually had much value. Now, I earnestly hope that that's not going to be the attitude taken towards psychedelics, and I don't think it will be. But I think what it does mean, to Jim's point on this, is that there will be early adopters when these compounds are FDA approved who say, yes, we see the value, we've read the studies, we've followed this, or organizations like Anthea come to them and make the case, and they say, yes, we will cover this. And there will be others who are slower to adopt. Impossible to predict, the pace of that and how that will happen. They're always early adopters. I guess what's impossible to predict is how many they will be and how quickly it will become broadly approved.
I'm going to just interject one clarification of terminology. We tend to use the term insurers broadly for these third-party payers. Technically speaking, there are insurers who assume much of the so-called risk. They pay for treatment out of the premiums they collect. And there are third TPAs who provide the mechanism for payment and for all the things that we've been talking about, but actually just administer an employer's fund for things. So when we refer to insurers, we're including all of that, but we may in our upcoming discussions talk a little bit about the specific role of TPAs.
Mm-hmm. And another implication of what Jim is saying is an employer who is self-insured. In other words, they are taking on all the costs for their employees. They can decide what they want to cover or not to some extent.
Yes.
Early adopter self-funded or self-insured employers are likely to be the first to cover psychedelic assisted therapy. Again, nobody knows the future. The large national insurers may be a little slower to come around, but again, we don't know that for sure. But in terms of decision-making about coverage of something, to Jim's point, employers that pay for the healthcare costs of their own employees, which is about 2/3 of employers in this country, so it's not insignificant, it's most of them, have a good say over what they cover. And the large insurers make their own decisions in terms of what they offer if they are the insurer. Sorry, that gets a little inside baseball, but if you can follow it, good. And if you can't and have questions, you can.
No pun intended, but getting into the weeds is necessary here.
Right. Yeah, the weed isn't covered yet. I don't, well,
No.
the weed is covered yet to some extent, but
not fully, right? Yeah.
yeah. So let me, we're going to sort of just close out this slightly more structured part with two other things, and then really open it for discussion. And maybe I should have led with this, but like in any situation of contracting, there are rights and there are responsibilities. So in a health insurance world, patients, providers, and the payers, they each have their own particular rights. The patient, of course, the client, has the right for care that is indicated and covered in their policy. They have the right that it should get paid for. The provider has the right to get paid for their work and to get paid fairly at a fair rate and in a timely fashion. And the payer also has a right, as I've mentioned before, they have the right to be assured that the care is safe, that's effective, and that it's appropriate for the condition. With rights come responsibilities, as hopefully we learned in school somewhere along the way. So patient's responsibility in a health insurance situation is to seek treatment of a provider who's, quote, in network is the term. In other words, a provider who has been vetted and credentialed by a payer and has a contract. A patient may also have the responsibility to pay certain co-payments. Probably most of you are familiar with that. Provider, has a responsibility to adhere to standards of quality and of appropriateness of care. The payer has the responsibility to, as I said, to pay a fair rate and to pay it in a timely fashion. So I'll just close with, just as an example, and this is not meant to be an advertisement for Anthea, but it's because I know it best. For those of you who are providers, what does it mean to join a network? First is to make some statement of interest to the provider. So in Thea's case, on our website, you can suggest that you are interested. Then there's an application process. Everybody's applied to various things over the years. Some supporting materials get sent, that verify your license, something about your training program, things like that. And then there's a discussion of rates and a sort of how this is all going to work. And if that all sounds good to both parties, then there's a contract that is signed between the payer and the provider. Then, of course, there's a lot of orientation and hopefully, and in our case, we're committed to sort of ongoing support over time of providers as they do the work. Jim, anything you want to add before we open this up for just questions, discussion, comments, thoughts, ideas?
No, I think we've given a good outline of what this is all about. And I'm really interested in people's questions and what people would like to learn more about in this area.
Great. So thank you, Dan and Jim. So if people have questions, please put them in the chat or use the raised hand. I have a question just asking if you can elaborate a little bit more about what you're doing within Thea right now and the pilot that you're doing now and how you see that kind of rolling out.
Sure. Some of you may be aware of this. There was some coverage in the New York Times a couple of months ago. We have launched what you'd call in the business world a proof of concept, meaning, can this actually work? In which we developed medical policies about, when is psychedelic assisted therapy appropriate for what conditions. And right now it's ketamine. Ketamine is really the prototype. It's not a true psychedelic, but it's a prototype for the way in which MDMA and psilocybin and others will be used in the future. So we developed a set of policies and program descriptions and all the things you need to do. And then approached Dr. Bronner's in San Diego. And some of you know of David Bronner's, who's a huge enthusiast in this field, and said, do you want to offer ketamine-assisted therapy explicitly to your employees? And he said, absolutely, because they look forward to offering true psychedelic therapies in the future. And so they took us on as their administrator, third-party administrator, and very enthusiastically offered ketamine-assisted therapy as a benefit to their employees, about 300 or so people. And when I say enthusiastically, we presented at their annual meeting, a lot of excitement there. And we really had no sense of how many people might step forward for ketamine-assisted therapy, and have been happily surprised at the numbers. So that's part one, or one side of the equation, contracting with a payer, an employer. And of course, the other end of the equation is a provider. So we have a a clinic in San Diego that went through all the steps I just described, you know, the credentialing and the contracting and the orientation and education and all of that. So now if you're an employee of Dr. Bronner's Soaps or a dependent, you can go to this clinic and get your ketamine-assisted therapy. In the case of Bronner's, fully paid for 100%. They're a somewhat unusual employer in that they fully cover without co-payments treatment. That's not typical, but that occasionally is the case. So that's been up and running since January. And we've had about 20 individuals who've gotten a full course of ketamine-assisted therapy and others who are interested to do that and in a process of evaluation. So that's point one. Point two is we have quite a few employers who want to follow Bronner's. We're holding off a little bit because we're in a process of fundraising now. We want to be sure we have enough money in our bank account that we can scale up and take on more employers. So we've proved it's doable. We've got the sort of test case underway. We're in the process of raising funds so that we can expand in 3 or 4 metropolitan areas as our next step in the coming months.
Couple of points. Anthea is a TPA. It's a third-party administrator, namely where the employer provides the funds to actually pay for the treatment. They simply pay Anthea a fee to administer the process. It's not a fully insured product at this point. And I think as we learn more about this field, there may come to be insured products, but at the moment, I think TPA is the most likely vehicle. And Dan pointed out, in the TPA structure, the employer can decide what they want to cover or not. So that simplifies the process a lot. Someone in the chat, sorry. Okay. Someone in the chat provocatively said, responding to Dan's earlier comment, was that a reference to the insanely expensive Alzheimer's drug by Biogen by any chance? I think it was like $50K a month, so that would kind of make sense for their denial of coverage. That's part of the sort of yin and yang of health insurance. If something is extremely expensive, it's going to get closer scrutiny, and it's going to have to demonstrate effectiveness for patients, so that by spending a lot of money, you're reducing costs for other treatments for that patient, and moreover, having a huge effect on the patient's life. So, and the answer, I will say, just as I heard it, yes, that's what Dan was talking about. And so that is part, and that's not only a part of how things work in our American system or in European systems that are more like ours. If you're in the UK or Canada, there is an assessment of the cost effectiveness of treatment. And that is necessary, again, to equitably make resources available for everybody.
Mm-hmm. Mm-hmm.
Thank
I
you.
also want to add, and I should add this at the end, but the intention of all of what we're saying is not to be a tremendous downer here. Psychedelic assisted therapy will get covered. And at some point, the new compounds, I'm confident, will get FDA approved. What we don't know about the future is, how quickly, how rapid the expansion will be. So this is not by way of trying to sort of dampen people's enthusiasm here.
Great. Thank you, Dan. Thank you.
Dan, should we pick up on some of the other questions in the chat?
Well, here,
Sure.
I'll help you with that, Jim. We've got some
Sure, thanks, Mike.
hand raises, so let's alternate. So Marcos Rosenberg?
Yeah. Hi, can you hear me?
Yes.
Can you hear me? Okay, yeah. Well, thank you for this subject. I'm not so sure that, because I was in and out, maybe I don't think you covered question that I will ask you. I'm in private practice. I joined the 2021 last year cohort of CIS. I have the certificate for psychedelic assisted therapy. And currently I want to work with people dealing with end of life, etc. And I have several cases on the two sides of the spectrum. Also, I have younger people, students from BU, etc., that they use psychedelic for recreation, etc. So I want to use whatever we are developing in the model to do integration, and most of these clients are insured. So I'm curious to know about, one is the liability issue. Two is in the reporting, for example, I don't use the concept of addiction. I use other concepts, anxiety, depression, etc. So I'm curious to know what your answer is. What can we do? What can we do in this situation? Because I think that for one side, there is an opportunity for these users to work with, to accept what we are offering, because in reality we offer. They don't look. They look for therapy. They don't look for a psychedelic assisted therapy. And I include that. And I offer and I describe lengthily the concept of integration. So creating like a bridge between the recreation and the psychotherapy experience.
Yeah. Let me take a try at that, Marcos, and see if I understood your question. To the extent to which the work you're doing, or anybody who's a therapist is doing, that is integration, in other words, a psychotherapeutic conversation, that's psychotherapy. So if you're licensed to do it, and if you're in a payer's network and they are paying you for psychotherapy, you are entirely free to do that. I mean, what insurers don't do, happily, is they don't come into your consulting room and say, you can talk about this, but you can't talk about that, or you can use this technique, but you can't use that technique. So to the extent to which the work you are doing is in dialogue with a patient therapeutically, it's no different in a certain sense from the payer's point of view than any other psychotherapy. So you don't have, you don't have liability there. You know, if you have somebody in a psychotherapy and you recommend them into the underground and something doesn't go well and they complain that you sent them there, that's different. You know, then you know that you know, if they sued you for that, that might be a problem. But integration work, not a problem.
And that's not going to involve the insurer, because the insurer is not
That's right.
going to pay for the underground.
That's right.
Yeah, great. Just to close this, I thank you for the answer. Superb answer, in which I like it. But just to close the concept, I don't suggest the use of the medicine. I don't say anything. I don't recommend underground. So I really stay on the side of, I avoid all that. They come to me and they describe what they are doing. So when I learn what they are doing, I start to expand the concept and to let them know that there is a richness in what they are doing, that we can work in on doing the integration.
Right. Let me add one more thing, and then we take other questions. I mean, what Anthea is about, what we're about, is getting coverage so that if you as a clinician want to sit with a patient while they are under the influence of a psychedelic, or you have a prescribing authority and you want to prescribe a psychedelic, and that's all part of your treatment, and get paid for it, that's our goal.
And if I can just kind of piggyback on your mentioning of treating members of the Boston University community, they're kind of an example that I'm familiar with. Their employees are covered in a self-insured plan where Boston University themselves could decide what will be covered or not. Their students are covered in a separate plan, probably from Blue Cross in both cases, but a different plan, which may well be an insured plan. Many student plans are insured. That's the sort of thing where persuading an employer like a BU or an educational institution to offer coverage is going to become more and more important.
Thank you. So I'm going to go to the chat, and Shippen, do you want to ask your question, please?
Thanks, Ann. Yeah, Jim and Dan, thanks for this great presentation. I turned to the classic protocol and the 6 to 8 hours, and I know that folks are trying to figure out how to make this more realistic, but how does the insurance industry look at something balanced again, possibly 3, 4, 10 years of therapy to deal with PTSD? Can you just sort of talk about how one thinks about that conceptually?
I'll take one swing at it, and then Jim. There's no single and simple answer. You said the insurance industry, and it's big, and there are many parties involved. So I sometimes wonder, a course of let's say MDMA assisted psychotherapy, let's say it's $15,000-$20,000 of cost to the payer. I'm just picking a number that's moderately educated. Is that expensive, or is that a bargain? Well, this is going to be partly your point of view, and it's expensive compared to an hour of psychotherapy, and maybe it's expensive even compared to a year of psychotherapy, although now the costs are starting to approach one another. Is it expensive compared to another 20 years of trying this, that, and the other thing for all the disabling symptoms of PTSD? No, now it becomes a bargain. So how a payer thinks about it, I'm trying to illustrate kind of a range of ways it could be thought about. PS, how does it compare to the cost of an expensive cancer chemotherapy? It's also probably a bargain. Those of you who are not in the healthcare world, I mean, some of the treatments that are well covered by insurers are hugely expensive. Now, well, I don't want to go on too long-winded, but yes, I mean, some will be interested in what's called cost benefit or cost offset. How well can you demonstrate to me that $15,000, pays for itself over time? And there are people actually who are starting to sort of do those kinds of studies, but it takes time to have numbers that are large enough to make strong cases.
So this is where I would pick up on something Dan said a few minutes ago, that the insurer will not step into your session and say you can talk about this or not talk about that. But what they will do is review how many sessions they will approve in a given sequence. And that's where an insurer who is, I could say well-informed, or I could say sympathetic, can be very important. That is what's called utilization management. And it's a highly controversial subject, even for physical therapy, let alone for psychiatric or psychedelic assisted treatment. It's an ongoing topic of discussion. I might even say dispute. And again, different insurers are going to take different approaches. Some insurers would do all of their evaluation of that in-house with their own staff. Some insurers contract that out to companies who specialize in coming up with approaches, not to use the word formulas, for that, but who, because they are a contracted service, are also often judged more directly on how much money do their decisions cost the insurer. So it's not a one size that fits all as to how that takes place, and it's an important topic of discussion.
Yeah, and can I ask a follow-up question?
Sure.
The follow-up question is, if a group in Boston decides they want to, in fact, approach an insurer, do they come through Anthea? Is there an advantage to having a alliance with a group like Anthea, which has vetted this field and is knowledgeable? Or do you go directly?
I would say that we're not at that point yet, but Dan, go ahead.
I mean, you could go directly, but an insurer, that hasn't thought about this much yet, doesn't know much about it, doesn't have the expertise in-house, and has a lot of other things on their mind, it's going to be very, very hard, I think, probably to get their attention. Part of our approach is to not bring one or two providers to an insurer, but is to bring a network, in other words, a as large a possible group of properly trained and credentialed providers, and to come to a payer and say, we've done all the things that you expect of the surgeons who come into your network and the cardiologists. We've credentialed them, we've vetted them, we have programs to monitor quality, to measure outcomes. What the term of trade, turnkey operation is what they sometimes say. So that if an insurer believes that this is coverage, there's a host of activities and decisions that detail that they don't have to take on. So I think, we think that that's where we can play a useful role.
So one applicable term, as you say, Dan, is turnkey operation. Another is carve out. An insurer could, well, and this hasn't happened yet, but it could in the future, say, well, we don't have all the expertise in that area, but we've reviewed what this other company does, and we will contract with them for all of our patients and their cases that fall into this area. And that is a known concept, particularly in the behavioral health treatment world. Again, there can be a distinction between those carve-outs that are aimed on reducing costs and those that have a mission to increase access, like an Anthea does.
Thank you both.
Thank you. So, John Phelps, we'd love to hear from you, please.
Unmute. Thank you. Great discussion. I have two quick questions. One is, early on was talking with Leah and looking into making an investment in Anthea, and there was an arm planned to establish a standards board for practice with psychedelic medicine. And I'm very curious as to where that stands and if that's evolving. And also, secondly, when the decision was made to make Anthea a nonprofit, both my sister Jenny and I directed some funds to the Patient Assistance Fund. And I'm curious about the status of that. Is that in use at this point, or are there candidates for that?
Let me take it briefly in reverse order. The Patient Assistance Fund is not yet active because right now we have only the one pilot where the care is being fully covered by Dr. Bronner's. What John is referring to is an effort to raise, philanthropically raise, you could call it scholarship money, for people either who don't have health insurance or for whom the out-of-pocket payments are still a problem. In terms of the certification, there are a couple of activities independent of Anthea. There's a group that's forming a board certification process, a board and a certification process, I should say, which is a very detailed undertaking. but directly mirrors what you see in the rest of healthcare, which is, I'm board certified as a psychiatrist, so I had to do a certain kind of training, and I had to sit for exams and so on and so forth. So it's to build an analogous process to certify that clinicians are properly trained. And what there isn't yet is an accreditation process for training programs, although I think there's a lot of thinking in the works for that as well. So that's certification is a kind of good housekeeping seal that a provider knows what they should provide. Accreditation is the good housekeeping seal that a training program is training appropriately. This is a young field, and there are people who are working hard on those things. And the third I'll mention is a professional association, which has also been formed up, which is a place that is both a kind of a trade organization for providers, but also an organization that's going to promulgate practice standards, which, for instance, as in Thea, will be very important to us. We don't want to have to invent the practice standards. We very much look to trained providers to take the lead on that.
And there would be a complaint process if someone had a negative experience or was taken advantage of. That provider, a complaint could be made against that provider, and a process for resolving that would be initiated. Is that?
Yes, in a number of directions. So as we build a provider network, we have to have an appeals and grievance process, and that would be called a grievance, actually, and we would look into it. Yeah. But at the same time, if somebody is board certified, a complaint is made to their board. So there are a couple of quality sort of oversight functions. One is in Thea, one is the board, and yes, there would be a couple of places of recourse for problems like that.
Great. Thank you.
Thank you. Brooke, from the chat, I see you have two questions. Maybe ask the one you is most burning to you. Honoring our time.
I guess I'm going to ask maybe then the second one. So I've had conversations with Mass Health about covering like EMDR intensive sessions that will run 3 to 6 hours. And so they were saying that because they've changed some policies, that's now doable. Worst case scenario is that they would call me if they saw really extensive billing, but wouldn't deny it. And thus far, I have not actually had any issues getting coverage for 3-hour sessions. And so I'm curious, is it the administration of ketamine in that time that would change coverage, or is it generally just based on the amount of time that an insurance plan covers in therapy?
I'm not quite sure I got the question, Brooke. Make the
Yes.
again.
So if an insurance company like Mass Health will cover, let's say, a 3-hour session of EMDR, would they hypothetically cover a 3-hour session regardless of what you're doing? Or once somebody is, say, administering ketamine, that is changing things and then you're not going to cover that?
Well, again, that probably harkens back to whether they cover ketamine-assisted therapy at all. But if they do, then for sure they recognize that the medicine sessions are, 2-3 hours. And there are procedure codes. Remember, I referenced this sort of code language that allow a provider to indicate, I administered medication and was with the patient for 60 minutes, 90 minutes. You can add what are called modifiers to say it took, 2 hours, 3 hours. So the language in the codes exists to communicate how much time you spent in a given session. The payer then has to agree that, yes, they will cover a ketamine session up to 3 hours. They're not going to cover a ketamine session that takes 12 hours. I'm exaggerating a little bit. So they will have a system by which when you send in a claim, it might say anything up to 3 hours, we pay no questions. If you say the ketamine session took 12 hours, we're going to ask a question.
Okay, so it would be like that matter of every other thing that I'm aware of, like the coding doesn't include the intervention. It just includes, like, it might be administration of medication, it might be therapy, but it wouldn't include what that medication is or what that therapy is, other than like basics that might be in the note, which is maybe more for billing purposes. But with something like this, it would have to be coded specifically by the intervention.
Well, Dan, you may have a clearer answer than I do, but there's also a distinction that covering a standard length session, say a 50-minute session, is going to be handled automatically. Covering a 3-hour session, you've been successful with, but I think if there's a volume of those, they're going to say, well, why are these sessions 3 hours? And you say, well, because if you administer ketamine, you better stay with them for 3 hours. And that's where you start to get into there looking at, have they approved the therapeutic or not? Dan, would you agree with that?
Yeah, and again, this is where, what we are doing as we, work with employers to cover this is, we're transparent with them about what they will be covering. So that, that it'll be this many hours. That I'll give you an example. So in our pilot, we spent a little time looking at what's the common, or what's the sort of typical median practice of a ketamine-assisted therapy course of treatment. It's that, even ketamine is a new field in the way that it's used now, and there's no hard science that it's 4 medicine sessions, or it's 6, or it's 8, or it's 12. So we just went out to see what's actually happening out there, and we decided, when we approve a treatment, it includes 6 sessions with the ketamine, plus some preparatory at the beginning, plus some integrations along the way. We said that seems to be a reasonable community standard of a basic course of ketamine treatment. Side note, after that, a provider can come back to us and say, it's been very helpful, but they're going to need some boosters, as it were, and then we can go ahead and approve something that's additional. The one other thing I will add is, right now, MAPS is in conversations with Mass Medical and to establish CPT codes specifically for MDMA therapy, and presumably the same will happen for psilocybin. That will be codes that, to your point, Brooke, that actually are specific for the medicine. And they're doing that partly because the sessions are going to be long. And so rather than the provider having to add all these multipliers and so forth, let's be explicit. This is an MDMA session. It's 8 hours and it has a unique code for it. So I think the future there will be new codes unique for perhaps maybe not for every medicine, but certainly that will relate to the medicine and how long a typical session needs to be.
Great, thank you. So I just wanted to check in and tell everyone what I think we should do, because we don't have a lot of time, and Rick is with us, but we have a little wiggle room. Sherry's trying to answer questions in the chat because some of them were easy to answer pretty quickly. So I'm going to call the last 2 people with their hands up, and then I'll let Dan and Jim wrap up if they have anything more. So John Terrio. Oh, we can't hear you, John. We just lost him.
He's still there.
He's still there and he's not on mute, so something's.
Well, maybe we'll go to you, Bill, while John is figuring it out. Welcome, Bill and Brian. Nice to see both.
Hi, good to see you guys. Thank you.
Yeah.
So just curious, if it might really be helpful and with the appropriate permissions to invite some of the key decision makers from these major insurers to actually sit in and observe unobtrusively and get a sense of what psychedelic medicine can be. I just wonder, I think of like our Sunstone site, but possibly others as well, where we could really interface in a way where they really get an experiential sense through direct observation, interfacing with the team. Like, this is what it is. Potentially, this is the complexity, the amount of staffing and time. And I wonder if that kind of inviting them in, including them in a more direct way might be helpful.
Brian, thanks for that. I mean, my first reaction is absolutely, but it'll be a matter of who and when. So once an insurer gets interested enough that they want to learn more about this, they will have, somebody like me or somebody called medical director or behavioral health director or somebody, and they may indeed say, go learn a little bit more about this, or that person may say, I want to learn more about this and come back to the ultimate decision makers within my Blue Cross organization, what have you, armed with that kind of information. So that's a generous offer.
Thank you. And John Terrio, have you been able to come back? Can people see John? I can't see
We
him.
can see him, but we can't hear him. Yeah, the lips are moving.
Yeah, and
Can you hear me now? Can you
Yes.
hear me now?
yes.
Okay, good, thank you. The question is, let's say we take into account the fact that there are Americans that are traveling around the world and receiving treatment in clinics internationally. Would you at all be point in that direction for American insurers, or is there room for international insurers to be serving that community? Any thoughts about that?
So I've
ahead.
got a little bit of experience with this, Dan, maybe you do also. I've done a little bit of work with some national insurers on international coverage. And there's 4 or 5 either general or specialized national insurers that cover out-of-country treatment for Americans. Not in this area yet, but are familiar with that process. One of and that's more specialized for Americans who live overseas. If it's just people who are traveling, it very much depends on your particular coverage. For example, traditional Medicare covers nothing outside the United States. One of the, to me, major selling points of Medicare Supplement and of some Medicare Advantage plans is that they do cover treatment outside the United States. So it's a process of discussion, and the starting point is probably going to be, what do they do for non-behavioral treatment outside the U.S., and then go to the argument of parity of coverage for behavioral health care.
Yeah, the other thing I'll add on that, John, is often there's another dimension as well, which is urgency. So if you're out of the country and the need is urgent, they may cover, but if it's, call it elective, you're going to be home in a month's time, then that's, they're not likely to do that. And the other piece is what I spoke to earlier, of course, is contracting and credentialing and all of that. Somebody who's in a faraway place, the payer is not going to know much, if anything, about the provider. And so they're generally going to need to believe that there's urgency so that they go outside what they otherwise feel is their responsibility to be sure that the provider is, properly trained and vetted and so forth.
Understood. Thank you. Thank you.
Great. Well, thank you everyone for your good questions. Thank you, Dan and Jim, for the presentation and for giving us the time to answer these questions. I'm sorry I couldn't get to every single one of them, but I think we answered most of them. And I wonder if you, Dan and Jim, have any final words you'd like to share with us.
I'll just say I'm happy, I think hopefully my email address is somewhere on that Google sheet that Sherry was referring to. Happy to take questions offline. And otherwise, just to end with what I said before, I know this is not the most exciting of stuff. This is not, you know, but it's important, and it's necessary so that psychedelic assisted therapy doesn't become just a carriage trade, meaning those who can pay for it get it, and those who can't afford it don't. And that's really where we play a role. And that role involves absolutely being good to providers, absolutely being good to patients, but also recognizing that, you know, payers have some needs as well. And that's what all that credentialing and contracting and vetting stuff is about. And it's for the safety of the patient as well.
And I'll just conclude by saying, as you may have gathered from our discussion here, this is a work in process. And there's a lot more to come. So please, thank you for the opportunity to talk with you about it today. And as regular participants, Dan and I will probably update from time to time.
Yeah, happy to do that.
Yeah, no, we'll look forward to including you in the updates. So thank you. Thank you.